Welcome to this new summer series from CTSNet, Cardiac Surgical Arrest and International Conversation. My name is Jill Lay. I'll be your moderator for 5 recorded sessions, followed by 1 live session that we hope you'll join us for. I'm joined today by 3 advanced practice nurses who'll be representing the various societies during this conversation. First, I have Tara Bartlett from the Society for Cardiothoracic Surgery in Great Britain and Ireland, Cristina Ruiz-Segria from the European Association for Cardiothoracic Surgery, and John Whitlock from the Society of Thoracic Surgeons. Thank you all for joining me today. Today's topic will focus on general practices around cardiac surgical resuscitation, or CALS as it was originally known. This is the protocol that we'll be discussing today. It shows the various steps one should take when approaching a resuscitation of a cardiac surgical arrest, and you should all be familiar with this protocol, which we'll be discussing today. My first question is for Tara, where this all began. Tara, what are your early recollections of cardiac surgical resuscitation, or CALS, being adopted by your society?
Thank you, Jill, and welcome to everybody. I think the first thing to say is that this is the 20th anniversary of the CALS course in the UK from its origins. And I think probably early people's tales would be around being involved in a disastrous outcome, but also one that was quite troublesome and scarring for the people involved in terms of what they had to go through. So Joel Dunning, who was very much part of this in its origins, put together a course that essentially key take-home messages were that, we don't come to work to do bad, we come to work to do good things. Our patients, unlike the traditional cardiac arrest patients, are likely to have a reversible cause that's an iatrogenic cause. And so we have moved through the courses in the UK to create numerous courses across the country that now go across the world and the whole of Europe as well. And hopefully the take-home message is that we are providing people with the equipment to recognize the deteriorating patient and the framework on how to manage things when they go well by dividing it up. Just this year, we have managed to have 61 courses across the UK in 33 different hospitals. There've been 4 train the trainer courses, which I'll come on to because they're hugely important for being able to spread the word, so to speak. There's been 444 delegates already this year, so there should be about 650 by the end. And we're on the sort of the 5th manual. We've had 3 learning courses and 5 iterations of the guidelines. So we have learned as we have gone along and improved. And hopefully patients and the staff involved now have a much better outcome and process for, recognizing and dealing with this emergency that's common to everything that we do, really. Thank you.
What a journey that all started.
Yeah.
Christina, how have things evolved for the European Society?
Well, I was very lucky because I was born doing cardiothoracics with Joel Dunning, who was the creator of all this. So for me, it's always been like, it's basic. It's no doubt about it. But in the society, in EAD, it's been more difficult in terms of bringing the concept. So I think Joel and Adrian Levine took a while to get through the guidelines and the protocols, and it's still today there is no available to everyone. Yes, we've done lots of courses. I've been lucky enough to be in one of them as well outside in Europe, but it's still the concept. It's not everywhere. So I think it's a lot of work that we need to do. From EADS, we've run one of our webinars for nursing, and it's been on CALS, and it was super accepted. It was lots of questions. It was really exciting. So I'm sure, and every time you run like a talk in EADS with research and the concept of CALS, it's always a lot of people who come to you and ask questions. So it's still a lot of education that we can do, definitely in Europe.
I absolutely agree. I think we have similar challenges in the States. John, can you respond with how things are going here?
Oh my God. Well, we have certainly come a long way. I was first introduced to the protocols when I happened to take a position here in Boston, and unfortunately, the unit that I was hired onto had recently had a death that was as a result of a cardiac arrest after cardiac surgery, and the staff themselves were the larger driver and requested, even on my interview, if I would help them develop training so that we could teach the staff how to respond to emergencies in a more coordinated and thoughtful way. It was always amazing to me because I've been in cardiac surgery ICUs for most of my life, that any of the ICUs that I worked in had this open chest cart that existed, but no real training or structure around what we were supposed to do with it if we needed to perform that procedure. So I am proud to say now that we've had over 200 people go through training at my hospital alone, and we've expanded the training to our intensivist team, the code team, pharmacy, and all the disciplines that are involved in this care.
I would just add to that that, you know, the experience in the States really started in 2010 when I brought this here from Joel Dunning, but it was 7 years later before the STS adopted it. So I think we still have quite a ways to go, but there remains a lot of interest in the States. So my next question really is, you know, that was the beginning. John, how have things evolved over the last, you know, 8 years in terms of what you've seen at both at your hospital and in the States in terms of the progress we've made with cardiac surgical resuscitation education?
Yeah, well, I did. COVID took a big hit in the spread of the cardiac surgery resuscitation guidelines, as did everything else. So we had a bit of a hiccup there for about 3 years, I would say, in the spread of the protocols, and there was limits on our ability to teach the course because of our quarantines. But I've noticed in the last 3 or 4 years in particular that we've had a rapid growth throughout. I work in the city of Boston, and the teaching hospitals in Boston have all adopted at least some form of the protocols, and I see them being taught at national organizations. I'm happy to say that much of the training in the United States is driven by the nursing profession with support from our physician colleagues. But it seems like, Jill, when you started teaching at NTI, that created the fire over here in the States. And so now we're enjoying the benefits of all of that.
Cool. Tara, what sorts of changes have you seen in the UK? Are people teaching the same way? Have things evolved?
Yeah, it's a great question, isn't it? Because I don't think we should ever stand still in our business. We should always be up to date. So as I said earlier, you know, 650 people hopefully through by the end of this year just in the UK. We are on the 5th iteration. So when I first started teaching, we have reduced the size of the course in terms of length. We have changed the content of the course, for example, in general, in terms of the slide set and the amount of practical sides of experience that people have were on the course. Specifically, you know, we have removed adrenaline, and we have looked very much, which we'll come on to at a later point, I suppose, about whether to pace or not to pace. I think the evidence that has been gathered across the UK has enabled us to reduce sort of our target opening time. So it's now under 5 minutes and has been since very early doors. But initially, you know, we were anecdotal, and now we have evidence from 2 pure units where there are no general patients to be able to say say that, you know, outcomes are greatly improved by the sort of getting in under 5 minutes. I think that, you know, to go ahead and shock, the changes in terms of reducing, giving chest compressions unless there's a delay of over a minute are really significant. And I think culturally things have really changed. So in the early providers, I think that it was very much allied health professionals and anaesthetic support. And our surgical cohort were less involved in the course initially, despite Joel, Adrian, and the other members that were surgeons. Mainly because I think, you know, they aren't expecting things to go wrong, and when they do, they're not the first people to be in the situation often when things happen. So the other things that have changed are the number of different people that are able to either open the chest that are non-surgeons according to what is correct within their own governance processes in their institution, or to make sure that everything has been set up for the surgeon to walk directly in, all of which reduce the time to get back in the chest. And I think now culturally, you know, as John said, it only takes one bad outcome and one disastrous open chest for everybody to start thinking. You know, I can remember one of the hospitals I was working in, we had 2 situations where very early doors things had not gone as well as they should, which brought, you know, real emphasis to CALS and how we move it forward. And as I said in the first question, you know, not only does it prove better outcomes, but the outcome for the staff involved is hugely better than it had been. So I would say the trajectory over the 20 years has been a change in both the actual evidence base, but also the cultural approach, and the fact that we've then been able to work across Europe and myself across the States with other colleagues to bring it to a much wider audience. And now it's across a much wider audience in Australia, Asia, etc.
Absolutely. This is definitely an international standard now. And Christina, you've been doing some exciting things with training at EACTS. Could you share what sorts of changes you've seen?
The changes are slightly different because the type of the clinicians that you do in the training is slightly different than the ones that I'm used in UK, for example. So in UK, you've got a lot of nurses, you've got a group of, in Europe is less nursing-led things. The power is on the medical staff. So in some way, it's very difficult to justify to get your nurses out of the training and to justify that you're doing a training for nurses or for the wider team, which for me is the whole team. So the difficulty is this one. So that's why it's difficult to even think about it, that you're going to spend one day when your number of nursing staff or the ratios that you have in ITU, or it's probably double than in UK. So so I work with the concept of maybe doing something different. So I had the privilege to work with this team in the Netherlands that they developed some VR. So that kind of it was a training.
Virtual reality.
Yeah, virtual reality. So that was a good idea, and some people from some doctors from Spain and from Russia, they kind of highlight that will be really good because our nursing staff, they don't have the time to attend a dedicated training or maybe a full day, especially when you have to revalidate your cards. So I think there is a lot of ideas and there is a lot of positive things that we can do, and definitely webinars. I mean, I think the most important thing is for people to understand, or for surgeons, for doctors, that this is, when you get someone out of a cardiac arrest, is a team effort. Otherwise, it's not going to get out. And you can do the most beautiful repair of the mitral or the most beautiful graft in the world, and you have to maybe the best surgeon in the world, but if your team is not identifying that the patient is going to arrest, or they're not quick enough to get the patient with the right therapy that they needed, the shocks, the CPR, or whatever it needs by the algorithm, I think your chances of this patient outcomes, and we've seen that in the literature, so we don't need to prove to anyone. We've got the data, but it's just the concept. It's different because it's different population in Europe. I'm not sure in the States, but in Europe, definitely. Although we're getting more nurses into advanced roles, but we're not there yet. So, but they are encouraged. We will encourage from EADS, definitely from the nursing background, to get more people trained. So.
I think John already commented on the fact that we really see this as a nurse-driven process in the United States. And one of the things I learned from him is that this doesn't have to be an all-day course. He added, for example, open chest codes to their annual training for their ICU. So everybody gets exposure to it, even if they're not on the heart team necessarily. Taking the slide decks from online programs like I've created and using them in quality assurance meetings. I mean, I feel like there's so many forums where you can educate, and my goal is not to train surgeons, but to make sure that a surgeon showing up in emergency has a qualified team to assist them. So I think these are.
If I could just say, Christina kind of reminded me of something I would emphasize and point out, touching as many people as you can is really turned out to be, for me, the goal. And so regular in-unit mock arrests has been the best way for me to reinforce the knowledge, and things that we learned during COVID in terms of multimodal education have been extremely helpful to me. For instance, one of the hospitals in my system wants to adopt the protocols, and I was able to direct them to the website that you recently got up and running that provides us with a starter course kit. That allowed me to have them get a bit of a head start on the training. And then when I go in, I just reinforce the concepts and we practice together.
Thank you. Again, I think that this has kind of been my aha moment is there are lots of ways that you can use these materials to get this point across, and it doesn't necessarily have to be an all-day course. Christina, we've discussed the importance of debriefing. I know all of us have had this conversation before, both after scenarios as well as after actual events. Could you share with us your approach for how you debrief and maybe some thoughts about why that's so important for your providers?
Yeah, I think we all, I mean, since the beginning, I'm sure Tara, how she put the concept of the human factors and so other things that they're not into the bigger scheme of CALS, but they needed to be discussed. And I think debriefing is not a new concept. It's been there for a while, but it's really important. It's just a 5 minutes that you get after when everything is sorted, when the patient is it's finished, and then we can just have a 5 minutes and have the point of view of everyone who was there. With everyone, I mean everyone, even the medical student that was behind looking, because these people are the one that they are seeing us how we action, and they can see we are coordinated, we are not, and it helps us to kind of self-evaluate ourselves. So from an external totally point of view. So I always consider to have everyone, and even been a few times when junior staff, they feel mortified because we're not always going to get a good results, and we can have bad results, but that encouraged for them to understand what happened as well. Because we may give all our efforts, we may done the right things, we follow the guidelines, the protocols, we haven't managed to get a good outcomes, and we need to learn as well that, and that comes with experience. It's nice to kind of also have that time to talk to the juniors and embrace that. But I think it gives us a perfect opportunity to get the team together, talk about what happened and self-evaluate ourselves, not just as an individual, as a group. So I will definitely highlight it to everyone. It will be should be essential part of the CALS at the end, put that debriefing.
Absolutely. John, is that something that you incorporate with your practice?
You know, I've had varying degrees of success with that at my institution, but it has, in the last year or so, seemed to have uh, had a grassroots kind of evolution. And so I'm very pleased to see that the teams are now, because oftentimes I'm not here to direct that, but the teams are now taking initiative to do a brief debrief in real time. One of the things that I think might have been helping this process is I do a more formal debrief that we offer virtually for anybody that was involved in the event. So whether they're here or not, we can all have an open discussion, and we include um, all of the members of the teams. We're finding now even some of our unlicensed personnel could be traumatized by these events and need our support as well. So those formal things have actually kind of, I think, fed into the real-time debrief.
Thank you. I like the fact that that's so inclusive and that it's virtual. Tara, how about your debriefing experience? Any additional thoughts there?
Yeah, I mean, I think both Christina and John made some really valid points. We want to get better at what we do, and it's twofold, isn't it? It's one about the practical elements of what you do, but it's also people's memory and what they take away from it as well. And so Christina alluded to the human factors. It's not just about what we say, it's how we say it, what our body language says, and whether we are inclusive or not. And you know, the reason that this course originated was because Joel, in his junior doctor sort of experience, had a very poor experience and wanted to make it better for people. So in terms of the trainers and what we look at from there, we very much look at not just what is said, but the eye contact and the body language and the tone of voice and the level of voice. And the, you know, I can see you're nodding to me, you know, those sorts of things that also give reassurance and allow people to feel as good as they can in such a difficult situation. And we all learn through positive experiences, not negative experiences. So although this might be a very difficult encounter, if we can make it as positive and as structured and have a framework to follow, you're not testing your memory. Everybody feels secure in what they're doing. The MDT is really part multidisciplinary team, are all part and parcel. You know, and I can remember a cardiac arrest where one of our unqualified staff said very quietly in my ear, Tara, should this be plugged in? And it was the end of the oxygen. So I always credit that individual for saving that person's life, because at the end of the day, you can be fixated, and that's one of the things we look at for what we're doing in terms of our team roles and in terms of the actual protocol itself and the human factors, and you can miss things. And so to ask us, as have the confidence as team leader, to stand back and say, can I just go through number one, number two, and check everyone's doing, and then to say in a welcoming way, you know, have I missed anything? Can anybody else think of anything? And so I just think we learn from that and we take that forward. And, you know, the course may be in its 5th iteration, but we need to be, you know, continually reviewing what we're doing. And I think John and Christina also, just to say quickly, talked about how often you practice. It's about being familiar. So there's the e-learning. Your resources are fantastic for people to get ahead of the game and learn. But also, you know, our cardiac surgery doesn't happen very first thing in the morning. There's a gap there, isn't there? We could have a bed space set up and we could spend 10 minutes running through a scenario of the deteriorating patient that doesn't end up arresting and doesn't need their chest opening, or one that does. And then everyone's a little bit more confident. And one of the other things we do in the units that I've worked in is we have cards, or we allocate roles at the beginning of the shift. So it's not something that you do in an emergency. And all that planning and all that comfort that that gives definitely makes a huge impact.
Thank you. I think the debriefing actually is just one of the most important things we can do for our staff. And just real briefly, we trained our step down unit not to do the full reopening, but to do the shocking and the pacing strategies. And there was a nurse who was quite experienced and very reluctant during the training and said, I can't imagine myself ever defibrillating a patient all by myself. And I said, you won't. You've got your colleagues here with you. Sure enough, she was the very first nurse that found herself in this position. She shocked that patient, she saved his life, and she said she felt absolutely confident doing so. So, this is what we get when we talk to our staff and make sure we're working with them. So, thank you all for those perspectives. I do want to get into the various provider roles. I think there's some differences about who does what. And so, I'd like to ask, starting with Tara, what roles do your providers typically take during these arrests, and who is accountable for reopening?
So that's a really good question, isn't it? Because when we teach the course, we want everybody to be involved, whatever sort of, when I've taught it in Hong Kong and all over the country, different countries, you want everyone to feel that they can take each role. In the reality, when it comes to the actual reopening, you need to have the people who are the best person for that role. And it may well be that you've not actually had a recent practice, etc. So I think possibly in the initial instance, the more senior nurse on the unit will take the lead role. I think someone who's comfortable with airway will take the airway role in terms of setting things up, and then if an anaesthetist comes, they will take over. And in terms of the defib, number 3, then I think that can be anyone who's comfortable to do it. In the UK, it's part and parcel of all nurses and allied health professional training if they undergo the course, and actually making a difference between knowing what's CALS and what's the ALS protocol is very significant as well. In terms of the team lead, as I say, it tends to be a senior nurse, and the bedside nurse has done number 1. In terms of drugs, again, it's usually one of the nurses or an allied health professional that's qualified to do so, but it can actually be combined with the anaesthetist role as well. So long as you have good two-way communication, confirming what's been asked, what's been delivered, and what's been done. And then in terms of managing the unit, managing the equipment, as I say, it's the lead nurse. Who opens the chest? It really depends on who feels able. In most instances, it will be a surgical background person. So in England, that is either a surgeon who is in a senior part of training or a consultant. It's very, can easily be one of our surgical care practitioners because they work in theatres and they work at the chest, or it could be an experienced, advanced clinical practitioner who may be a nurse by background or maybe in the role with an allied health professional background. But essentially, it's about how that team all works together and having, clear, concise instructions, knowing your individual roles, but communicating as a team in a way that, values everybody that's in it and is able to sort of, step in and help. So I think that probably is how we do it across the team. And I think as the years have gone by, more people feel more comfortable to do it. What I would say is, as I said, allocate at the beginning of the shift, speak up if you're not comfortable, make sure we have regular training, make sure you know what the governance is for your individual unit and what you are licensed or able to do. And then afterwards, have a proper debrief to check that, things have gone as well as they could do, or if they couldn't, what's the lessons learned? What can you do differently next time that either changes the outcome or changes the experience of everyone that was involved?
Perfect. Thank you. Christina, how about in your practice? Are you seeing a similar practice with roles, or is there anything different that you're seeing?
When we train in CALS in my unit, I always say, please, during the training, while we're here in this room, having a play role, just try to do any other roles that you're normally not doing, because this is the only way that you're going to be able to play another role. Because in real life, as Tara said, I totally agree, you're going to go to your comfortable role. So we had a reopening just yesterday here on the high dependency, which is not the easy way. It's a bit more complex, at least for us. Definitely, I mean, it was at least 3 of us that we work as a faculty on the CALs, and we all went to our normal routine ones. I went to the chest, she went to the airway, because this is where more comfortable we feel. So yes, have a play while you're doing the training, or scenarios if you have some kind of virtual reality, or do, but in real life, you're always going to go to where you feel more comfortable. You will have always maybe the chance to, or I don't know if it's luck or unluck, to be the first one, and maybe you need to open a chest. And again, I'm from a center where not only Joel Dunning was the person who deals with CALs, who create CALs, if not also the first nurse in ITU who opened a chest. So, so for us, we've seen it. Probably at that time protocols, they weren't in place, but now definitely. And we keep saying when we're doing CALs, it's what about you train for and what you're comfortable, and especially if your surgeons are happy for you to do that and your anesthetists are happy. So again, it's your team. So you need to speak with your team, with all the surgeons, and everyone needs to be happy if there is a case, there's a nighttime, there is no one around, or the registrar is busy with another patient, because it won't be the first time that you have 2 reopenings at the same time, or someone who is in A&E, then maybe you need to crack on. But you need to make sure that you raise that to your team. I think that's principle is there.
Jill, could I just add to Christina's comment there, which I thought were really wise comments, and one of the points she touched on is, even if it's not your normal role, if you've practiced it, you have insight as to what the individual who is doing that role has to do and is going through. So you can preempt things for them, and you have an understanding, if it doesn't go quite right, how to help, or if it is going well, how to just give a reassuring smile or nod and say, well done. And all these things really make it work well together.
I mean, if you have the opportunity to go into a very controlled theater when you're doing a reopening that is all stable, you just take into theater and have the opportunity to scrub and cut some wires, that probably give you what you're saying, Tara, this hint of confidence in some way. Yeah.
Well, Joel has always advocated
Joel
that,
did
hasn't
that.
he?
Joel
Across
did
the
that.
units. He says if it's your patient and you're by the bed and the patient deteriorates and needs their chest opening, but you're going back to theatres, go with them and you do the open chest, just so that you've experienced it, really.
Yeah, we took senior ITU nurses before to theatre, just to have a feel to what is in real life, because if you haven't done in real life, it's easier sometimes to kind of get the feel that, as you say, that you're doing the right thing, or you're seeing you're doing the correct things, isn't it? So yeah, they enjoy it a lot.
Clearly, for providers that are going to be doing the reopening, I think that sort of practice is essential. In the States, and I've written a couple of papers and have one coming out, we have to be careful with credentialing. And it even says that in the STS document, that you've got to make sure that anyone doing the reopening is trained to do so, has the credentials to do so. John, did you have anything you wanted to elaborate?
No, only to reinforce what Tara and Christina are saying here. The only thing I'd say is remember that we're really trying to prepare people for worst case scenarios. So that isn't the comfort, that's moving away from your comfort zone. So although not explicitly spoken, that's kind of what we're all doing. And when I teach about the different roles, I always emphasize the importance of being flexible. In my unit, for instance, we may have a census that goes down to a point where I might only have 3 nurses in the unit working on a night shift. So everybody else that's showing up has not been formally trained, and they're going to have to think about how to deal with situations like that. But that's exactly what we're trying to achieve anyways. So, and if we get too rigid about roles, then we almost limit our ability to respond to emergencies, right?
Yeah, I agree. I think the only thing we don't do is open. I mean, we have every other role that we train providers for. My final question here to close this out is there's very good data that that sort of training has a really positive impact on staff. And John, I know you've looked and done some of this work. Could you comment on your research and what you found and how this really impacted the staff that undergo these events?
Oh my God, Joe. This is absolutely my favorite part of this whole journey. Watching the staff grow and take great pride in being able to respond to emergencies like this is been the most fulfilling part of the whole work. On a personal level, I've had people, nurses, thank me actually for preparing them for emergencies, even when the outcome wasn't good. They valued not feeling helpless in this really critical time. I did, however, do a survey in the very early days when we first started training because I thought, no, let me see if it's really making an impact. So I asked the staff that had been trained to rate their comfort level or confidence in performing in different parts of the various protocols, but specifically to open chest arrests. And we found that the the people that did respond that reported a high or very high level of confidence started at 13% before we started the training and ended up that 66% of those people that answered after the training had a high or very high level of confidence. It was even more, I think, dramatic for the people that had an average level of confidence at the end. Before the training, 53% said that they had a pretty good level of confidence, but after the training, 93% of those people said that they felt confident. So it's been a very empowering thing. So I can't talk
Wonderful
enough about
data.
it.
Thank you. Tara, have you found something similar?
Yes, absolutely. And over the years, obviously, people have gone to the course and gone back and been full of admiration for it and talked about it. So I suppose just building on what John said, the course also covers the deteriorating patient. So the idea is you avoid having to open the chest and that you pick up the early signs of deterioration and possible reversible sort of impact that you can have. Quite early on in the course, I had suggested that we needed to do some evaluations on a Likert scale of your pre-learning and your post-learning. And similarly to John, people who were scoring sort of on the Likert 1 to 5 scale, sort of, 0 to 2 in the beginning, sort of 90+% were scoring 4s and 5s by the end of it. What I do think is interesting would be to take that back into units, and that's where the national courses don't do that, and we've moved to sort of more individual courses for units now, in terms of the sort of 33 different units across the UK just this year have put on a course. It would be interesting to review that at sort of 3, 6 and 12 months as to how people still felt, and that in itself would feed back into guiding how often you need to train, because I'm sure doing things annually is not enough. So the small learning that John and Christina and I have advocated in terms of on the unit and the talking about it and using other resources are very helpful for keeping that confidence up, but also the skill set.
Christina, you must be feeling something similar working in a hospital where Joel Dunning is. Are your staff incredibly empowered to feel okay about these events?
I think it's like anywhere, is it? But I think the satisfaction of training, satisfaction of having someone, because Joel, I mean, it doesn't do CALS but we have someone else who took the leadership for that, and having someone who really is interested in training people, I think that's the impact as well, because nurses, we get training, but most of the time is mandatory training, which is not related to our day-to-day work. We don't understand most of those trainings, but this is really, really, you can see that they can use it, they can, and it makes feel, and you feel good. When you have a reopening, it works well, and you've done what it was meant to be done. So I think from faculty and from staff is always, they always love to come to CALS. I think it's quite fun to come, to go through all the scenarios and test yourself. Like, for example, when I went to Barcelona, so which is outside UK, I don't think so. The nurses there, they get trained on resus. I don't know what everywhere else is, but resus is not like a mandatory thing that you have to do every year. So this type of training, when you train for the wars, it's very unique. And no, I mean, you get your normal basic skills with CPR and but no something that is preparing you for the worst. So they were so pleased.
I agree. We've been running this course at my facility since 2009, and people still love it. And what I find is the people who've done it a lot really help the people who are new, and I believe that translates significantly into their actual practice. So we're going to close with a lightning round here. I have a question for each of you. I want a 1 or 2 word answer without elaboration. I'll start with Christina. Which dysrhythmia do you find the most challenging?
I think after all the reopenings that I've seen in my life, probably asystole.
Asystole.
Yeah.
All right. Tara?
Bradycardias.
Bradycardias. John?
Rhythms that involve pacemaker issues.
Got it. All right. So we're going to stop right there. I thank Christina, John, and Tara for your participation today. I look forward to taking up this question on addressing bradyarrhythmias, and we'll get into a little bit about compressions and actual hand position and CPR during our next meeting as well in 2 weeks. I thank you all for your time today. Thank you for connecting with us, and we look forward to seeing you at our next session. Goodbye.
Thanks, everyone.
Thank you.
Thank
Bye.
you.